everyone, and welcome to another episode of Clinical Conversations brought to you by the Royal College of Physicians of Edinburgh Trainee and Members Committee. My name's Marilena Giannoudi and I am on the TNMC, and today I'm delighted to be joined by Dr Sarah Schoeman, who is a consultant in genitourinary medicine at Leeds Teaching Hospitals. Dr Schoeman, hello and welcome.
Hi, thank you for having me.
Thank you for talking to me today. I think it's really important that we cover this topic because it's not something that all medical trainees will have exposure to. So I guess the most fitting first question for me would be, how does a sexual health clinic run and what are patients faced with when they attend your clinics?
So it does depend a little bit on where you're based, where you're working, where you're living, as to what your local sexual health service setup is. Mostly the sexual health services are separate now to HIV services because the commissioning has changed slightly. So HIV services are commissioned by NHS England and sexual health services are commissioned by local authorities. So there have been quite a few changes to the way that sexual health services are run over the last couple of years. A lot of the sexual health services are community-based, even if they're run by a trust or another organisation. They're often what we call integrated sexual health services. So they do provide sexual health care, but also contraception and emergency contraception care as well. And then sometimes the sexual health services and the HIV services are in the same place, but often they might be in slightly different places. And obviously when we talk about sexual health, as a genitourinary medicine physician, I do a lot of sexual health, so chlamydia, gonorrhea, syphilis, herpes, all the common STIs that you can think of, but also HIV. But in Leeds, our HIV services is in a separate location to the sexual health service, but we work very closely and I work in both services. But it will vary depending on your region and where you're working. And the best thing to do is to Google clinical local sexual health service. Most services do have very good websites, which are not only clinician accessible, but also patient and public friendly services. So there'll be a lot of information locally on where your sexual health service is, how you can contact them, how you can signpost patients to them as well. Obviously, if it's an HIV care that you're wanting to coordinate, then I would look specifically for an HIV service. But if that's not obvious, then the sexual health service locally would know how to contact the HIV service if those two services are slightly separate.
And so does that mean, again, I appreciate that this may be dependent on your area, but you don't necessarily need a GP referral to access your services?
Yes, absolutely. Both for HIV services and for sexual health contraception services, you don't need a GP referral. Most patients that we see self-refer, so they are ways that an individual, for example, in Leeds, we've got a website, there's a phone number. Individuals could just phone up and say that they want to be seen. There might be a few triage questions, a bit like if you phoned your GP practice, and then they would hopefully be booked into the appropriate appointment. Some services, well, we do accept GP referrals as well. For example, if patients have gone to their GP and the GP thinks it's appropriate for us to see them in the sexual health service, then the GPs can refer directly in as well. But that's not a requirement for access to sexual health services and HIV services as well.
And when a patient does come to your clinic, do they just see you or do they see multiple members of the MDT that you have there?
So again, it depends a little bit on your location and how the service is running. The majority of sexual health services are consultant-led with kind of a lot of nursing leadership as well. So it sometimes, again, it depends on the type of thing that you're attending with. It may be appropriate that you're booked in to see a doctor, but depending on how the triage has worked, it may be appropriate that you're seen by our very experienced nursing colleagues as well. We have healthcare assistants who are able to do some basic screening of vaccinations. And if somebody comes in and they're booked in the wrong appointment, then, we would just discuss with the other colleagues on the clinic floor at the time as to whether we would be able to, if they need to be seen by somebody else, we can often arrange that while they're there. But if not, we might have to bring them back if there's something else that we can't deal with on that day that requires a specific individual to see them. But that's very rare. The majority of times, when they come in, they're often able to see just the one individual with maybe some support from healthcare staff, depending on what else needs doing. We do a lot of microscopy in clinic, and we give a lot of vaccines, we take a lot of bloods and samples. And if you're doing an intimate examination, chaperones required as well. So often you're not necessarily only seen by one person within the service, but a lot of people are. So it depends what you come in for and how that service is working, really. We would try and get individuals to be seen by the most appropriate individual, but sometimes circumstances change and we just need to be flexible and we try and accommodate everything as much as possible within that clinic visit. But sometimes we do need to get patients to come back if there's something that we can't specifically deal with, but that's not very often.
And I think you touched on this, but just for me to clarify, does that mean that your patients don't need to have a diagnosis in order to access your care? Can they come with potential concerns of a sexually transmitted infection or symptoms of that and be diagnosed under your care, or do you need to have that diagnosis?
No, absolutely. We don't need to have a diagnosis confirmed for them to be able to access our service. And for most sexual health services across the country, that would be the same. So if individuals are wanting just asymptomatic screening because, they've had some sexual contacts and they don't have any symptoms, they haven't been informed that they've been in contact with an infection, it's just a peace of mind. Often those things can be done through the sexual health services. A lot of sexual health services have online testing that you can access. And again, that's available through your local sexual health service, usually the website. It can direct you to those options that are available for you. If people need blood taking, sometimes there are blood postal kits as well that services use. So patients can do their own blood samples at home and send those back for HIV and syphilis. But if there are additional things that need doing and additional monitoring, then they would need to come in. If they've got symptoms, we would want to see individuals in clinic, maybe do some microscopy if they need vaccinations. Obviously, we can't do that remotely. And if they're a contact of an infection, for example, gonorrhea, we'd want to be doing gonorrhea cultures as well. And those things we can't do so much remotely. So we would need those individuals to come in. But not everybody needs to come in. And absolutely, a lot of people that come in to see us, they've just got symptoms. They're concerned that they might have an infection or something else going on in relation to their genital and sexual health. And so we would see them depending on what their symptoms or what their concerns were.
And do you mind, because again, you've kind of mentioned this, how does contact tracing actually work? What do we as doctors that aren't really involved in the service need to know about contact tracing?
I think most other clinicians and services don't get involved in contact tracing. They would refer to their local sexual health service for help and support, and we've got the expertise to do that. It depends a little bit as to what infection they've been diagnosed with, because contact tracing isn't appropriate for all sexually transmitted infections. For example, we wouldn't do contact tracing for somebody who's diagnosed with genital warts or herpes necessarily. It's more about things like gonorrhea and chlamydia, syphilis, and obviously HIV. We would work with the individual to explain the importance of contact tracing because, A, if they're likely to have sexual contact with that individual again, if we treat the person in front of us, like we call the index case, and we don't treat their sexual partner, then they potentially just get reinfected. So they then have to take the treatment again. And a lot of sexually transmitted infections have got no symptoms at all. And it's important to explain that to the individual because they might be presenting with symptoms, but they say their partner hasn't got any symptoms, but we would still need to treat their partner regardless of whether their partner's got symptoms or not if they're a recent contact of that infection. We would work with them to do that, to look at their current partner and who they're most likely to have sex with. Again, those are the most important individuals. But if they've had sexual contact with other people within different timeframes, depending on the type of sexually transmitted infection they've been diagnosed with, we'd want to ask them for as much information as possible. We keep all of our sexual health records more confidential than other health records. All health records are confidential, but there are additional confidentiality requirements for sexual health records. And so if we're collecting information on third parties, we need to be really careful that information obviously isn't divulged inadvertently. So again, sometimes individuals coming to see us can be worried about giving third party information. We reassure them it's really important that we have that information so that if that individual then comes into our service or we're contacted by another service to say this individual has come in as a contact of an infection, we can make sure that their contact is being given the right treatment for the right infection. There are different options with contact tracing. So often the individuals themselves would prefer to tell their recent partners about their infection or that they need a sexual health check and that they need to go and get a checkup at the clinic. And so we've got ways of obviously working with individuals to make sure that that process works well and is the right process for them. Or we could do something called a provider referral. So that's when the individual index patient doesn't want to divulge that information themselves, but is happy for us as a sexual health service to contact them, their recent contact or contacts, and we would discuss with them in advance about how much information the index was prepared to share with us. Are they happy to say that Sarah's been into clinic and been diagnosed with chlamydia, and we would recommend that you make an appointment to come in for testing and for treatment as well? Or is it that you have been named as a possible contact of an individual with a sexually transmitted infection, we would advise that you come into clinic for testing and you may need some treatment. So we can be very specific or we can be a bit more vague depending on what that individual is comfortable with.
And kind of following on from that, I think taking a sexual health history is incredibly difficult if you don't do it regularly. And it's certainly something that when we're clerking, patients on MAU, that we should be thinking about these questions. But I think it's probably something that quite a few doctors in training may shy away from asking. Do you have any tips on, certain questions that we should be asking and maybe how we should be asking these more delicate questions?
Yeah, I think they are obviously very sensitive and personal questions. It's really important that if you're asking those questions that you are in a confidential space, so you're not necessarily asking the question in the middle of an open hospital bay where other patients can overhear because they're quite sensitive. So being aware of where you're asking the questions, I think, is really important. And then it's easy for us within the sexual health service because patients that come to see us are already anticipating that we're going to ask them some kind of more personal questions. But I would try and normalize it as much as possible. So, for example, if you've, got somebody presenting with just like a overall body rash, for example, you'd want to make sure that they don't have syphilis or HIV. So you could say something like, in all patients who present with a condition like this, we would want to ask some additional questions to guide us as to if we need to do any additional investigations in relation to any sexually transmitted infections, for example. So trying to normalize it. So these are kind of questions that we would normally ask rather than I'm kind of singling you out as somebody who I think's got a sexually transmitted infection. I think that can be sometimes what doctors are afraid that patients will feel that you're making assumptions or judgments. So trying to normalize it as much as possible. I appreciate that's not always that easy when you're not in a sexual health service, but thinking about how you can do that. And then just obviously saying that the information is confidential. And I would ask just, when did you last have any sexual contact? And was that with a regular or a casual partner? Is commonly what the terms we use. And was that with a male or a female? So give them the options. Don't assume that it's a male partner if they're female or vice versa. And did you use any protection when you had that sexual contact? And it's useful to talk about sexual contact because that can include different types of sex, as oral sex as well, not just penetrative sex, for example. We go into more detail asking about vaginal, oral, anal sex. I don't think you necessarily need to do that in a more kind of out of the sexual health service environment. And then we would go back. So other than the partner you've just told us about, when did you last have sexual contact with anybody else? And then, we would try and look at a time frame of about 3 months. So if they do give somebody else within 3 months, you could then say, in the last 3 months, how many other partners, if any? Again, I'm not making an assumption that you have or you haven't. Mm-hmm. In the last 3 months, other than the 2 partners you've already told me about, have you had, or how many other partners have you had, if any, in the last 3 months? So that's what we would suggest. So the most important things are really the number of sexual partners they've had. Protection or not is less relevant. And what type of sexual contact they're having. So if it's men who have sex with men, we'd want to do different sampling sites. So we'd want to sample from the throat, from the urethra and from the rectum, offer HIV and syphilis testing, chlamydia and gonorrhea testing to everybody. But the sites that we sample for chlamydia and gonorrhea are slightly different depending on the sexual contact that you're having. And then if somebody is a man who has sex with men, additional things that we would do within the sexual health clinic would include asking about vaccination, because we can vaccinate, so sexual health promotion and prevention. So thinking about vaccination for hepatitis B, HPV vaccination as well, we offer for men who have sex with men within the sexual health service setting. And then thinking about, do they know about HIV medication that can prevent people from getting HIV? So PEP, which is post-exposure prophylaxis, and PrEP, which is pre-exposure prophylaxis. What we would then offer screening-wise and also sexual health promotion, prevention, information would be slightly different. So that's why it's important to know kind of who they're having sex with, as well as how many sexual partners they've had and the most recent contact also allows us to work out about window periods and whether we need to do any repeat testing. Because if somebody's recently had sexual contact with a new partner, it can take up to, for example, 2 weeks for us to pick up chlamydia and gonorrhea. It can take up to 6 weeks for us to pick up an HIV infection. It can take up to 3 months to pick up hepatitis C or syphilis. So those timeframes allowed us to guide in relation to any additional testing that might be required further down the line.
And you've obviously mentioned lots of the different infections that you treat in your clinic. Without wanting to, take up too much of your afternoon, I was wondering if you could maybe discuss a couple of cases of 2 different kinds of infections that you've treated, just so, we just have a bit more of an idea of the kind of patients that you see, the symptoms and so on.
Yes, absolutely. That's fine. I think as a kind of background, if I just can take the opportunity to let people know, and you probably already know, most of your audience, that sexually transmitted infections are exponentially on the rise across the UK. We've had the highest number of new syphilis infections ever recorded in 2023, well, ever since World War II, and the highest number of gonorrhea cases ever recorded since records began, so that's since 1918. So there is a lot of sexually transmitted infections, and people can present in lots of different ways when they've got sexually transmitted infections. We talked about asymptomatic presentations, but especially with syphilis, people can present with syphilitic complications in almost any system, any body system. So they could present to ophthalmology, they can present to neurology, they can present to dermatology, liver, they can get acute hepatitis, they can present to the liver team. So just that people are aware, as you said, to be thinking of potentially, could this be a sexually transmitted infection that's presenting with extragenital manifestations? So other things that we also deal with as well that people might be less familiar with. So we're increasing gonorrhea resistance. It's a very interesting specialty. We've got kind of new infections as well that we're dealing with, something called Mycoplasma genitalium, which is a sexually transmitted infection that not many people outside of sexual health have heard of. So there are all these challenges, really. I think because we're seeing syphilis so much, I guess a case that I saw recently was a gentleman who came to the sexual health clinic with an extensive maculopapular rash. He felt well in himself other than this rash. He wasn't sure what it was. He'd Googled it, but had been having multiple different sexual partners outside of his kind of regular relationship. And I was able to look at his rash, and because he had the kind of classic, and not everybody with secondary syphilis rash gets the classic maculopapular rash involving palms and his plantar aspect of his feet as well, I was pretty sure this was secondary syphilis just by looking at it. He was a bit shocked at the thought. He had been having sexual partners outside his kind of regular relationship for a long time, but had never had a sexually transmitted infection before. And so we did treat him on the day, partly because actually he wasn't a resident within our area. So he was in the next couple of days moving back to his kind of usual area of residence. We did a full sexual health screen for him, including testing from his pharynx, a urine sample, and a rectal sample for chlamydia and gonorrhea. We did blood tests for syphilis and HIV. He didn't have any ulceration, so he didn't have any signs of a primary chancre. So we do have the facilities to do dark ground microscopy within the clinic, but there was no ulceration that we would have been able to get a sample from. And we talked to him about, he wasn't on PrEP, he was having sexual contact with lots of different men. So we talked to him about PrEP as well. He decided that he was going to think about that and probably start it at his local sexual health clinic rather than with us. We did some screening as well for hepatitis C and hepatitis B. He wasn't sure whether or not he'd been vaccinated for hepatitis B or hepatitis A. And then we also obviously got his syphilis treated, which involves IM high dose benzathine penicillin on the day. And then we were aware that his results were going to come back in the next week. So one of our health advisors then also saw him on the day as well as me, just to give him a little bit more time and space to talk about everything that had happened, because he was quite shocked that we thought that he probably did have an infection, but he was very keen to get treated. He didn't want to wait. And his results came back the following week, confirming syphilis, a kind of very recent infection. And also he had gonorrhea as well. So we would have kind of phoned him up with that information, linked him in with his local sexual health service, because he would have needed some treatment for gonorrhea as well. So on the day that I saw him, because we were giving him penicillin for his syphilis, I did gonorrhea cultures as well on the day that we saw him, because if I hadn't done those cultures on the day that we saw him, then the penicillin treatment that we treated his syphilis for would have made it more difficult for us to get any meaningful culture results from his gonorrhea samples. And so, yes, that was quite an interesting case because he had such florid secondary syphilis, and it's not something that's unusual in our clinic. I think For me, it was more about the fact that this gentleman had obviously been having some high-risk sexual practices over the last kind of several years, never had an infection before, and then comes in and, is quite shocked. And in a way, the fact that hopefully we reassured him that we could get things sorted, we could get things treated. There was lots of other things that we could offer him to kind of protect himself from, infections going forward as well. I hope that for him was a positive experience, although obviously it was quite upsetting at the same time.
And can I ask, how often is it that you see patients that actually don't have just one infection, but have two or more at the time of diagnosis? Is that something that's common?
It's very common. So we always say if somebody is diagnosed with one sexually transmitted infection, you need to check for all of the other sexually transmitted infections. We had a recent young gentleman who came to our service as a gonorrhea contact, and he did have some symptoms at the time. So we did microscopy and we were able to see the gram-negative diplococci under the microscope. He was a contact as well. So we would have treated him even if we couldn't see that gonorrhea under the microscope because he'd had contact with this individual within the last 2 weeks. But we were able to also, on the day, confirm that he definitely did have gonorrhea. So we treated his gonorrhea, but we did all the other screen as well. And he subsequently came back with a new HIV infection and syphilis infection. Going back, I guess, to the other question. So people with gonorrhea infection, 50% of them will also have chlamydia infection. So multiple infections in an individual is not uncommon.
And what is the most common or the group of most common symptoms that your patients tend to present with if, we exclude the asymptomatic ones or the ones that are the contact?
So for the most common symptoms are, if they're not asymptomatic or if they're not a contact, would be, well, for men, urethral discharge and or kind of testicular pain. People might present with ulcers as well. That's quite a common presentation. And then for women, again, it's a change in vaginal discharge because it's normal for women to have a discharge, but a change in vaginal discharge. And then sometimes obviously lower abdominal pain, pelvic pain. And then again, often people present with ulcers or genital skin conditions. Sometimes those genital skin conditions are not sexually transmitted, but often the first thing that people worry about, and it's good that they come to see us because we can rule that out, is that they've got an infection and worried about the consequences for themselves, but also very worried about passing that on to their sexual partners.
And amongst these patients, how treatable are the infections that you see, other than, I guess, HIV, which is a whole different kettle of fish?
Yeah, so most of the infections we can treat and we can clear. It's slightly different. Like you say, the viral infections are different to kind of bacterial infections. So the majority of chlamydia, gonorrhea infections we can treat, but we are seeing increasing gonorrhea resistance. And sometimes that can present a bit of a challenge for us because we are limited as to what other treatment options we have for gonorrhea infection. But on the majority of cases, we can treat those infections with things like genital warts with HPV virus. The majority of people do clear their infection over a period of time. There's no antiviral treatment for that infection. With herpes, again, it's something that people do have. It's a kind of a longer term condition. Over time, the herpes virus tends to get less problematic as people's immune systems kind of get more familiar with the virus and the virus can kind of burn out a little bit. And so for a lot of people, it doesn't cause kind of significant long-term problems, even though they don't actually necessarily completely clear the virus, but it doesn't cause problems. They become much less or at all infectious. More complicated things like Mycoplasma genitalium, we don't always completely clear the infection, but as long as a patient is kind of asymptomatic, then that's a sign of good treatment response, then we would be happy with that. HIV, as you said, is a long-term medical condition, but the treatment available for HIV infection is fantastic, and the majority of people in the UK who are diagnosed with HIV, so over 95% are on treatment, and of those who are on treatment, over 95% are virologically suppressed, so the virus isn't causing any further immune system impacts or damage, and it means that they can remain healthy whilst living with the virus. But also the additional benefit of that treatment response is that if they're virologically suppressed for at least 6 months on treatment and they continue to take their treatment every day, then they can't pass the infection on to their sexual partner, even if they're having unprotected sex. And that's something called U equals U, so undetectable equals untransmittable. And that's a really important message for not only people living with HIV, but all of healthcare workers understanding that significant change and how effective HIV treatment is.
Thank you. So I don't want to take up too much more of your time. I guess my last question will be, what would your advice be to anyone in my position, doctor in training, doesn't really come into contact with these patients very often and will mostly see them on the general medical tape? What should we be either looking out for? What should we be doing? Or is there anything that we can be doing better for these patients?
I mean, I think it's difficult. I think it depends on what they're presenting with, doesn't it? So if somebody's got genital symptoms, then not being afraid to ask them. For anybody presenting with these symptoms, we would want to ask you some questions about recent sexual contacts. Is that okay if I do that? To help us determine what other tests, investigations or advice we need to be able to provide you with. And then I think if you're working on general medical wards, make sure you do think about HIV as, potentially presenting with any general medical condition, as can syphilis. It used to be said, if you know the whole of syphilis, you know the whole of medicine, which is still very true, but HIV is very similar. It can affect any system. I think in all high prevalence areas now, there is funding provided by the government. So opt-out testing is happening routinely in A&E departments in very high prevalent HIV areas, which is mostly London, but some areas outside of London as well. And then they have recently announced that high prevalence areas will have some funding to provide opt-out testing for HIV, hepatitis as well. So we've just restarted that in Leeds. And so hopefully there will be more people who have come in contact with hospital setting and have had bloods for another reason that would be automatically being tested for HIV and syphilis. But if your patients haven't, and they're presenting with non-specific symptoms, then it's always worth thinking about, is it worth doing HIV syphilis testing?
Great. Okay. Well, Dr. Schoeman, thank you so much for your time this afternoon. For our listeners, just in case you're particularly interested in our conversation today and you're thinking about genitourinary medicine as a potential career choice, there will also be an episode on our other channel, Career Conversations, again with Dr. Schoeman, where we talk a bit about the career pathway and all the exciting things that you can do if you do decide to specialise in that area. So please log on to our Career Conversations podcast channel as well.
Can I just lastly say, if you're interested in GU medicine or want to know more about it, as well as the podcast, we have just launched in June a new website. So it's called Love GUM. So if you just Google Love GUM, there's a fantastic website with lots of resources available and links to how you can get more experience of the specialty, what the training pathway looks like. And there's a few video clips on there as well from consultants and from trainees. It's a good website anyway, just to have a quick look at, even if you're not interested in GUM, but you want to know a bit more about the specialty. But yes, Love GUM, #LoveGum.
I'll put it in our show notes as well, so you can access it directly from the podcast episode footnotes as well.
That's brilliant. Thank you so much.
Thank you so much. Thank you. The TNMC sister podcast, Career Conversations, supports medical students and trainees with career guidance and progression, as well as professional development. We wish to recommend our Demystifying PACES podcast series on career conversations. As some of you may know, in late 2023, MRCP UK updated the PACES exam format, so we developed this new series to support PACES candidates. Episodes cover exam organisation, calibration, every PACES station including key changes, and candidate perspectives.